Good morning, everyone. It's still morning. I think we'll just wait maybe 1 or 2 more minutes. Welcome to the contraceptive market session, the most exciting session in ICFP 2022. Yay! Thank you. It's already time. I think we're going to start. Please come in, walk in. We're just going to start. Thank you, everyone, for coming to attend this session and for coming early. As I said, we're going to start our session on the contraceptive market. Can I ask someone to perhaps close the door, please? Thank you. Again, good morning, and this is day 2 of the International Conference on Family Planning in Pattaya. What a wonderful city, lovely people. I'm enjoying this hotel and I'm enjoying the conference. So thanks to the organizers for hosting us so well. And I don't know who attended yesterday's opening session. Who attended yesterday's opening session? Wow, how did you feel? Wow, I thought that was great. So more seriously, today we will discuss contraceptive markets, which is a critical issue to make contraceptives available. If we want family planning for all, this is a critical discussion that we will have today. We will talk about accessibility. How do we maintain accessibility for all in such a growing market of contraceptives while prioritizing the most left behind? And in that discussion, how do we ensure universal health coverage? We have a wonderful team of speakers who have joined me on the other side and here today, who I will present in a few minutes. Before we start, I wanted to say just a few things about what does the family planning contraceptive market entails. Why is it so important and what does it look like? We're going to talk about that too. And most specifically, and as an example, I sort of looked at the analysis from the 2021 family planning analysis, family planning market report, which was jointly produced by the Clinton Health Access Initiative and the Reproductive Health Supply Coalition, which provides visibility and on family planning, and which provides also indication on procurement in the 69 family FP 2020 focus countries. And it also gives an overview on the recent supplier and procurement, and as well as the 5-year trends from 2016 to 2020. So why am I saying that? That analysis has been able to provide market growth. What was the driver? By what has been increased. And as you know, both UNFPA and USAID increased their contraceptive procurement spending from fiscal year 2019 to fiscal year 2020, with UNFPA spending reaching a 5-year high. However, recent challenges within the sexual and reproductive health funding landscape, increased stakeholder uncertainty about the evolving trajectory of future contraceptive procurement. So now, let me stand up and introduce my speakers. So we have 4 speakers today who are going to talk to us about the contraceptive markets. Number 1, we have Zaki Azauri. And Zaki is a well-known and accomplished professional with more than 20 years of experience in the field of pharmaceutical manufacturing in the Middle East. He is the managing director and co-founder of APS, a company that is specialized in setting up pharmaceutical manufacturing plants. And with a portfolio of many turnkey jobs in setting up pharmaceutical manufacturing plants and thousands of interventions in the same field, namely in providing pharmaceutical engineering solutions and installing processing and packaging equipment. Zaki's experience has led him to be a member of the board of several pharmaceutical manufacturing plants and is currently an advisor of IQVA for pharmaceutical manufacturing. His expertise spans from providing feasibility studies, complete engineering solutions, and also installation and commissioning, validation, and startups. So please welcome Zaki to the floor.
Thank you very much for the lovely introduction, Josiane. My presentation today is about the model and the case for hormonal contraceptive manufacturing in sub-Saharan Africa. Well, to give you a little background, in 2021, we prepared a preliminary business case for setting up a standalone manufacturing facility in sub-Saharan Africa that would be dedicated to the manufacture production of modern contraceptives for the FP 2020 countries in sub-Saharan Africa plus South Africa only. In one scenario, we looked at the facility that could produce both injectables and oral contraceptives. In another, at a facility that would produce only injectable contraceptives. Our preliminary business case suggested that the facility that would produce both oral and injectable contraceptives would not be profitable. On the other hand, the one that produced only injectable could be. And that's why in 2022, we were asked to look into the business case for the injectable only facility and to have a deeper look into that model. And we considered their economics and of establishing both a standalone and a shared facility. The approach was rather simple. The approach was to build a virtual factory. In other words, we attempted to estimate the cost of construction, equipment, labor, utilities, active pharmaceutical ingredients, land rental, and finance, and then compared those costs with estimated revenues. Data sources, a number of different sources were used in this project, and they were all government bodies operating in the targeted countries, and other qualitative interviews for local manufacturers, distributors, providers, regulators, to understand the marketing and distribution costs, expatriates and local salaries, bank loan rates, and MPA intake. The operating costs, the key assumptions. In the next 2 slides, we will describe the key assumptions, inputs to the model, beginning with the cost. As you can see here from the graph, the cost of money dominate operating costs. The loan is assumed to cover all capital and operating costs up and until the point that WHO PQ is achieved. We also assumed that the loan and all accrued interest would need to be paid back within the 10-year term. But that production and obtaining WHO PQ and the registration would not be obtained before the end of year 7 or beginning years, end of year 6 or beginning year 7. As you can see also, the second biggest cost would be the marketing, followed by the cost of API, excipients, and the packaging cost. So we had to take a look into the packaging cost of our facility. And for the revenues, as regarded, we assumed that the form that we'll be targeting would be the intramuscular MPA. And with this, we took an assumption that the subcutaneous MPA would take 50% of the total MPA demand, and that the facility would make only the vial intramuscular MPA. We used the National Department of Health volume allocation formula in South Africa to maximize both price and market share of the South African tender market, discounted the current single exit price by 20% to ensure rapid penetration of the South African private market, that rate being based on historical penetration rate. We also, for the FP 2020 countries, for the donor and subsidized markets, we used the UNFPA catalog price in the base case. And for the private sector, we used the wholesale sale price as shown in IQVIA's Kenyan audit. We assumed that the new presentation of MPA IM intramuscular would take 20% of the donor and subsidized market for MPA IM in FP 2020 countries and 12% of the non-subsidized sector. So these were the assumptions that we had to take into consideration in order to build the model for our manufacturing facility. So as we said earlier, we had two options to look at. One option would be to make this virtual facility be standalone. By standalone, we mean that we started from a green field and build the facility completely from zero, or to look into a shared facility. By shared facility, we assume that we find the local operator. By local operator, we mean a local manufacturing facility with whom we can make some kind of contract to expand his facility to produce this intramuscular contraceptive. So for the standalone facility, the profitability was not profitable and feasible project. Taking both options, whether to take into the commercial loan or development bank loan. So this was no-go project for sure. As for the standalone, for the shared facility, the share facility was more profitable than the standalone. In this case, the share facility was able to pay even for a commercial loan at the end of the loan period, given the assumption of the model, but that the risk of failure was too high in this. Virtually any change in the assumption would mean that the shared facility would not be able to pay the loan within the 10 years term. The case for the shared facility funded through a development bank loan, however, was more robust. For example, it would pay the 10-year term even if the interest rate will increase by 2%, the donor price fell by 15% from current UNFPA catalog, or share of South African public sector fell by 20%, or the WHO pre-qualification registration or peak market shares delayed by 1 year on this. So it was, for us, a good thing. And I remind you that the feasibility was assessed against two criteria. Could the facility pay off the loan within 10-year term? And how profitable would it be once the loan has been paid off? And we found out that the shared facility would be the best solution to provide the market with supply of intramuscular MPA. As a conclusion, the standalone facility is likely to be not profitable, and so it was ruled out. A shared facility is likely to be feasible. Profits are sufficient to withstand changes to key assumptions. Some of the key things that were not addressed in this business case are the challenging in accessing foreign currency to pay for active pharmaceutical ingredient, excipient, and packaging imports, risk of expropriation of and the instability of some selected countries to manufacture, potential expansion of subcutaneous presentation of MTA into the South Africa, or further reductions in donor prices for FP 2020 sub-Saharan African countries. The availability of matching funding, because let us remind you that when you go to developing banks, we need the local operator with whom we have to partner, we need him to fund at least 50% of the money along with the bank. So this also taking into account that we assume that if we find this partner that is willing to pay 50%. And just to give you some numbers, the cost of setting up a pharmaceutical facility as a standalone would be for 10 years period with the interest between 90 to 100 million US dollars. For a shared facility between 70, 75 million dollars. So these were the findings that we could find. And one of the also things to look at, the expansion of sales beyond sub-Saharan African FP 2020, because also in our model, we assume that our product will always be subject to tender, to tender business or public business. But it could be also a possibility for the operator to expand his portfolio to be exporting to other countries, other private sectors. So in summary, manufacturing of an injectable contraceptive in sub-Saharan Africa may be possible under certain conditions. Investigation with local manufacturer and development banks may be appropriate at this stage. Final word, an acknowledgement. We thank Denise Harrison and Jane Wangi, the Office of Population and Reproductive Health at USAID, and Morgan Simon and Emily Day of the USAID Global Health Supply Chain Program Procurement and Supply Management Project for the comments and advice. And I thank also Peter Stephens, who was supposed to make these presentations in my place. So thanks to everybody for listening. And at the end, I think we'll be available for any question they might have.
Yeah. Thank you so much.
Yeah.
Zaki, thank you so much for sharing this experience on local manufacturing of contraceptives and also the challenges. I think it was a wonderful experience to share, and particularly the challenges around, whether it's a shared facility or using a standalone. Thank you so much.
Thank you.
As Zaki said, we are going to have all the presentations, and maybe after the next three, we will take questions and any clarification from the floor. I forgot to introduce myself. My name is Josiane Yagibu, and I'm the UNFPA representative in Togo, and I have the pleasure to moderate this session for the next not 80, but maybe 60 minutes, the next 60 minutes. Thank you so much for attending this session. The next presenter is Paul Bouanchot. He's a senior research advisor in the Strategy and Insights team in Population Services International, PSI, where he supports a number of Francophone, Anglophone, and Lusophone countries in the team to generate useful, actionable, and robust research. And he is also the technical lead on a number of SRHR-focused research projects, including the Consumer Market for Family Planning Project. So today, Paul is going to present the differences in contraceptive prices between and within family planning outlets in urban and semi-urban Nigeria, and talk also about a prospective cohort study. Paul, you're welcome. Over to you.
Thanks,
round of applause.
Thank you. So it's my pleasure to talk to you today on behalf of the co-author list here, including my esteemed colleague, Anthony Noella, who's also on the panel with me. I wanted to start just with a raise of hands for anybody who thinks that access can be a barrier to FP use in this room. Okay, interesting. And keep your hands raised, or raise your hands, if you think that cost amongst other reasons is one of those access barriers. Okay, this is great. Thank you. You are not alone. So a substantial minority of women in Central and Western Africa cite lack of access, including cost specifically, as the main reason for contraceptive non-use. This is data from Sejin Hussein's 2014 paper, and we can see Western Africa in pink and Middle Africa in green. Up to 20+% of women in Benin specifically saying that they consider cost to be the primary reason for non-access of contraception. We know that specifically 15% in Central Africa and 10% of women in West Africa report cost as a subset of access barriers as their reason for non-use. In many countries, the private sector is a key source of contraception for the poorest users and for adolescents. This is based on data from Bradley and Shuras in 2022. We know that contraceptive products are often subsidized or free in the public sector, but specific subgroups, including the poorer segments of the population and adolescents, often obtain contraception through the private sector. So both these figures show in the dark blue bars the percentage of people accessing FP in the private sector, as opposed to public or other. These data are shown by country, the poorest users in the figure on the left, and adolescents 15 to 19 in the figure on the right. And specifically, we can see that in Nigeria, over 80% of adolescents reported accessing FP in the private sector. The private sector, and specifically non-facility outlets such as pharmacies and drug shops, and patent and proprietary medicine vendors, or PPMVs, might be perceived to have greater levels of privacy, a more reliable service, greater convenience in terms of wait times or their location, or might be considered to be more youth-friendly, which are reasons why people therefore access their FP in these locations. So a bit about the CM4FP study. Most existing analysis of FP markets have been reliant on cross-sectional data to date. As such, there's a real lack of comprehensive evidence that's able to track variability and volatility in contraceptive prices and other characteristics over time. So the CM4FP study seeks to fill that gap. It's a study that was funded by the Bill and Melinda Gates Foundation, implemented by PSI and with local partners, including SFH in Nigeria. Data collection happened just before the pandemic, so all of the results we'll see here. In fact, the data collection was cut short because of the pandemic, but we managed to gather multiple rounds of data prior to that happening, luckily. This was a methodological pilot. The idea was that we tested the feasibility and utility of a range of novel approaches to capturing information on the total market for family planning products in purposefully selected sites in 3 countries, in Uganda, Kenya, and Nigeria. These sites were predominantly urban or semi-urban. We used CM4FP outlet data for Nigeria in this analysis, and this consists of 3 urban and 1 peri-urban site, and you can see in the table on the right what those sites were. They were located in 4 different states. And to give you a sense of the scale of these sites, the smallest one was 5 square kilometers in size, and the largest was almost 30 square kilometers in size. These data are, on the outlet data side, a comprehensive census of all family planning outlets within the study sites. So what that means is that we went and found all public and private sector outlets located geographically within these locations. They were eligible for inclusion if they stocked more than just male condoms in the previous 3 months. And these sites could be fixed sites or mobile vendors. We conducted a longitudinal follow-up every quarter, and so we have longitudinal outlet level data from these locations over 3 quarters in Nigeria in 2019. Specifically in Nigeria, the outlet data includes facility and non-facility outlets, including PPMVs, pharmacies, drug shops, and community health workers. So a bit more on the methods for this analysis. We used audit data for each unique product. So that's a combination of brand and product type in stock in the outlet at the time of the study. In total, we went to 672 outlets. In order to assess product price and price variability between outlets, we used the earliest audit data that we had for any given outlet. And in total, we had data on, that should be products, 2,437 products in our data set for product price data. and we provide descriptive summaries of that. To look at differences between outlets and changes within outlets over time, we looked at all of the data that was collected over the 3 rounds of data collection in all of the outlets, conducted linear GE models, and we described changes in outlet level minimum prices over time. Outlet level minimum price change was our sort of measure of interest because we believe that that represents the kind of lowest barrier to access for a given product in a pharmacy. Obviously, there is a range of prices for each product, but minimum price was our focus predominantly. And the figure on the right of the graph just gives you kind of a representation of what these study sites look like. The study, in fact, collected data on household FP use as well as outlet FP availability and price. The larger area is the study site area where we conducted the census of outlets, and the smaller area within it is the household survey location, and we did repeated cross-sectional household surveys. So what did we find? We saw differences in availability of free products and posted prices amongst non-free products by outlet type and public-private type. Most commodities that were offered in the public sector were free, and a substantial minority of some other products were also free in private facilities, but not in private outlets. So this figure shows the proportion of free products in private facilities ranging from 100% of OCPs, 96% of male condoms to 89% of injectables being free in the public sector. Oops, sorry. In the private sector, it was much less common to find free products, understandably. Particularly for Lux, just 7.5% of implants and 3% of IEDs were free in private facilities, while both of these were available around 80% of the time for free in the public sector. Free products were more prevalent for short-acting reversible methods. So in private facilities, we found that 54% of male condoms, 28% of OCPs, and 17% of injectables were free. But very rarely were these products found for free in private outlets. And by outlets, we mean PPMVs, drug shops, pharmacies. So this figure is a little difficult to read, I imagine, at the back of the room. Apologies. Really what it represents is how messy the picture is, I guess. The figure shows actual price for each product. And while it's a really busy graph, I think what we can see essentially is that for short-acting methods shown, so male condom on the left, OCP, ECP, injectable, there's substantial variability in dollar price in the private sector. Private facilities in pink and private outlets in green. So we see for OCP, ECP, and injectable prices ranging from $0 to over $8 in the private sector in these relatively small areas in a relatively short period of time. The high level of price variability within products of the same contraceptive method type in the private sector compared to the public sector is shown also in the price standard deviations, where we see, for example, the standard deviation for injectables is over $2 in the private sector compared with 30 cents in the public sector. And finally, outlet level changes over time were really common in minimum prices. So most private facilities posted an increase in the minimum price for OCP in yellow, and injectables in green, while most private outlets reported increased minimum prices across all product types over the course of our 9-month data collection, 3 rounds of data. Increases in minimum prices in the public sector were very rare over that same time period, with no facilities with observed increases in minimum prices of condoms and less than 10% reporting increased prices for OCPs, injectables, and implants. Descriptive comparisons of the distribution of changes in minimum prices within outlets over time suggest higher volatility in the private sector, essentially, particularly in private facilities compared with non-facility outlets for injectables and OCPs. We see similar descriptive patterns for implants and ECs as well. And these facility versus outlet differences in price volatility are shown in the table. So you can see the median price increase for injectables, for example, is more than double in private facilities than in outlets. So quite large real terms differences in price. So what does this mean? I think really the picture that I want to give and the overall message that I'd like you to take away from this presentation is that there's a high degree of complexity in pricing, even in quite small areas across the set of products that we looked at, both in terms of different products, different prices and products, but also in terms of outlet type price differences. Higher prices and fewer free products consistently were observed in private versus public facilities and outlets, although there were still some free products available in private facilities. The variability in pricing between outlets of the same type underscores high complexity in these markets. Changes in outlet level minimum prices were common over these really short periods of time, 3 months, we're seeing increases in prices. But we did see some decreases as well, and so there's volatility in the market that we're not able to capture in other methodologies that take cross-sectional looks at these prices in outlets. We hypothesized that outlet level changes in minimum price might impact method selection and use of a preferred method, or initiation and resupply. And I think it's still really unclear to what extent consumers feel these changes in outlet level minimum prices. And we know that cost is only one of a complex set of things that influence method accessibility and choice, amongst other individual social and health systems level factors. But arguably, consumers with the least ability to pay might face challenges in terms of their method initiation or continuation or resupply in the absence of widespread availability of a low-price product option. So we think that these findings have important implications for the young and economically marginalized or unmarried populations who often prefer private outlets, but who might be vulnerable to even quite small changes in the price of their products. The study has several strengths. So the longitudinal prospective design means that we're able to really capture these changes in outlet level price of products over time. We included a whole range of different types of outlets, and we really tried to capture the total market for family planning products in these small areas, including mobile vendors who are often considered a dominant source of FP products in Nigeria. We got really detailed product data on all of the products that were audited, including different types of brand and formulation combinations. However, this was a methodological pilot, and the sites were purposefully sampled, so we can't talk about representativeness of the data at subnational or national level. In addition, we relied on outlet self-reporting of price data when the prices weren't posted visibly. We're not able to capture kind of informal or sliding scale pricing systems that we're pretty sure exist in these outlets. And we didn't capture the price of services, so insertions, for example. And we don't know what happens in terms of consumer behavior, like what happens when people experience these price differentials. These are all questions that I think we have for future research.
Please round up.
Sure.
Yeah.
So if you'd like to read the paper, it's available online as a preprint. Please go ahead and scan this QR code. And all of our data and documentation is available on the cm4fp.org website. The data is publicly available, and we'd love for you to use it and conduct further analyses. Thanks to our funders, the Gates Foundation, and all of our participants. Thank you.
Thank you, Paul. Brilliant presentation, showing us the difference between the differences in contraceptive prices and what can hinder access when we're looking at family planning for all. Thank you so much. Let's now move to the next presentation. The next presenter is Dr. Anthony Nwala. He's an experienced medical doctor, public health specialist, and a strong healthcare services professional with over 20 years expertise in public health intervention. He's an exceptional leader. He's a leadership fellow, talented at powerful team building, staff development, motivation, monitoring, and supervision, as well as advocacy offering an in-depth understanding of project life cycles and project development methodology with different organizations such as USAID, DFID, Gates, you name it. He has over 10 years of work in the public sector and over 2 decades of collaboration with the Nigerian Ministry of Ministry of Health and various other departments. Dr. Anthony has featured in many health policy development and changes, which has strengthened the health sectors in Nigeria over the years. Dr. Nwala currently works at Society for Health, for Family Health, as the Assistant Chief Program and Quality Officer, overseeing the reproductive health and family planning practice, MNNCH, PHC, and clinical services practice. He also provides support to the project in the organization. Warm welcome to Dr. Nwala.
Thank you.
So Dr. Anthony Nwala is going to present, he's going to demonstrate the role of patent and proprietary medicine vendors in the provision of short-term modern contraceptive in Nigeria. Over to you, Dr. Nwala.
Thank you very much, moderator. Thank you for coming. We'll be trying to demonstrate or to show you what we found in the private sector in Nigeria in terms of contraceptive services. Now, as a background, unmet need for family planning is 48% for unmarried women and about 19% amongst married women who are all sexually active. And this has provoked a lot of thoughts towards how do we improve these indices. And like already said from other presenters, we agree that access is a huge barrier. So how do we improve access? And to bridge this gap, we felt we should look at involving the private sector in provision of contraceptive services. And then we have a group, Paul already mentioned, the patent and proprietary medicine vendors, also known as drug shop owners or drug shops in other countries. And they, in Nigeria, have been reported to be the most popular source of contraceptive services. The 2013 NDHS puts that figure at about 60%. So about 60% of Nigerian women seek contraceptive services from PPMVs. So how do we bridge this gap? Stakeholders in the sexual and reproductive health space, as well as implementing partners and donors, have continuously, bearing in mind the role of the PPMVs, they've continuously tried to partner with the Federal Ministry of Health and other arms of government to strengthen these PPMVs and empower them to be able to offer quality health services. For this study, we leveraged on a project known as the DISC project, which is delivering innovation in self-care. The DISC is a Children Investment Fund Foundation funded project in Nigeria. And the focus of the project is to work with the local health system to create innovations that will support service delivery and that will foster knowledge and as well as demand generation for the self-injectable contraceptive, the DMPA-SC, as a part of a comprehensive method mix, thereby supporting women to, take, their health into their own hands. So this project, some of the outcomes include some women effectively managing their own sexual and reproductive health care needs, also help to improve voice, to improve agency, to improve choice amongst women aged 18 to 35 years. Also, there was improvement in the provision of information and capacity in the support of women through the user journey for self-injection, and of course, evidence-based innovations to address these gaps. So looking at what the DISC project is doing, we leveraged on the project to to go back to our study question and see what we could find. So this project was implemented mainly in this project has 3 foundation states, another about 15 seed states. However, we tried to look at this in 2 states, 2 of the states, which is Lagos State and Niger State in Nigeria. Lagos State presents more like an urban setting, while Niger State is a peri-urban rural setting. So we tried to, balance the two for this study. So the method, we looked at, we studied this within September and October 2021, where we selected 9 PPMVs from 6 different shops in both states, Lagos and Niger State. Then the PPMVs were mapped to be around public health facilities in the areas where they exist in those geographies. And then they were trained, and part of the training included what we call the moment of truth training. Now, the moment of truth training is, we found also on the DISC project that one of the major barriers to women self-injecting and accepting new methods is fear. Fear of pain, fear of different fears, fear of competency. So we developed a moment of truth training model, which is to empathically demystify those fears. So the PPMVs are also taken through this training. Now, they were also linked with the Society for Family Health Social Business Enterprise, so as a supply partner, okay? And then contraceptive service data from the PPMVs were collected in those 2 states, and we made sure that those data were able to get to the national HMIs in the country. So what did we find? So we found that out of from those 9 PPMVs from these 6 medicine stores in Lagos and Niger State, 172 of them have accessed services in Lagos, and 153 women, women of reproductive age, 172 accessed services in Lagos, while 153 persons were provided with different, contraceptive services in Oyo State. In Lagos State, we found that 3 methods topped the scale, right? So most women in Lagos accessed the pills, about 26.2%. And this was followed by women who accessed DMPASC, the self-injectable, at about 24.4%, followed by the male condom, which was about 10.5% of women before other methods. But on the contrary, in Niger State, we found that most women accessed the DMPASC. That's about 92.8% of women, while the others accessed the male condoms. So 2 methods generally in the Niger State, and about 3 methods in Lagos. Now, all this data were fed into the NHMIs through the support of the structure already provided by the DISC project, and then with the linkage from the social business enterprise of Society for Family Health, we were able to get the detailers to provide products to the PPMVs at a reasonable, affordable cost. Again, we try to ensure access to contraceptive. Of course, there's a free contraceptive policy in Nigeria for the public sector, so we made sure that linking them to the SBE was necessary to reduce the cost, and the reduction of the cost of purchase also reduced the cost of services from the PPMVs. So this is just what I've explained quickly. In Lagos State, this is what we found. Most women having the pills, then the DMPSC, and then the condom. While in Niger State, the yellow bars demonstrates what we found with the DMPSC and then the condoms in Niger State. So, this is just a graph showing, of course, we didn't concentrate, I mean, we had to do this within the method mix and of course in the confine of informed choice. So these are also the other methods that were picked up in both states, but our study found what I've explained. So finally, what did we learn? We learned that the DISC demonstrated support for contraceptive service data to be picked from the PPMV. So data documentation is a problem in the private sector, but if supported, we found that helped in data reporting in the country generally. And then harvesting all relevant data will also show the true position of modern contraceptive prevalence and other indices in the country. Furthermore, the private sector has its own logistics systems, and this can be harnessed to be complementary in the provision of wide range of FP commodities in the country. And then the PPMVs, who are one of the main front runners in the informal sector, can be positioned to actually add value to the healthcare system, especially in contributing to the improvement of modern contraceptive prevalence in the country. So thank you very much.
Thank you so much, Dr. Anthony Nwala, for giving this model and demonstrating the role of PPMVs and how they can add value to improving modern contraceptives. We will quickly go to the last presenter, True. I will also introduce our next presenter. Okay, so True works for DKT International in a variety of roles since 2013, and both in the headquarters in Washington, D.C., and in different field offices. He's now in the strategy and business development. He's now the strategy and business development director for DKT Women Care, and which is the DKT Upstream, a supply chain platform that works with suppliers and in-country partners to make family planning and safe abortion products more available, accessible, and affordable in more than 100 countries around the world. He's truly motivated by his work and the work in family planning because of the immense satisfaction that comes from raising a child and creating a family of his own, but as a planned manner. So please welcome True Overholt with me, who is going to present.
Thank you
Welcome,
so much.
True.
Thank you, Josiane, and thank you all for being here, and thank you to my fellow panelists. How much time do we have left? Just I can
You have
adjust.
15 minutes.
Okay, all right, then we're on time. So excellent, thank you all for being here. So interesting, we're gonna zoom back up. So we were just looking at the country level perspective in Nigeria. We're gonna zoom back up and then kind of, instead of looking at just a country, a global perspective, but then we're gonna zoom into a specific product market. And so this presentation is gonna talk about contraceptive implants globally as opposed to in one or two or specific countries. So broadly speaking, I'll give a little bit of a background on woman care, and then I'll talk about what we've done with this product over the past 4 or 5 years, and then what has happened. And then we can go into questions for everybody after that. So about woman care, we are an affiliate of DKT International since 2017. We work across a bunch of different products. We're a social and reproductive health social marketing, or a sexual and reproductive health social marketing organization. So we do everything with these products, and we engage a lot of different strategies, whether it's education, whether it's marketing, advertising, whether it is distribution, promotion, training, right? We use a lot of different interventions to try and create an enabling environment for these products to be used at the country level. And so I'll get into the story of what we've done with Levoplant. but we also have other products. And so this is just one dimension of what DKT Woman Care is doing globally. So in terms of how we work, we are really a platform. And so we connect the suppliers, like this graphic, if you look on the left side, this is the supply chain. So the left side are the suppliers, the manufacturers, the people making the things that we use. And then the right side are the patients, the ultimate end users. And so we straddle all these different points in between. When you think of the phone in your pocket or the lanyard around your neck, there's probably 30, maybe 40 different actors in the supply chain that get this thing to you. And the more complex the product, the more complex those supply chains are. And so we try and flatten that. We try and make it as streamlined, as simplified as possible. And that yields certain efficiencies and reductions in cost and improved transmission of information throughout the whole system. So to get into Levoplant in particular, how many of you, just a quick raise of hands, have heard of Levoplant, are familiar with Levoplant? Okay, that's a pretty good number. Nice. I'm glad to hear that. Glad to see that. So it is a 2-rod levonorgestrel implant. It's been WHO pre-qualified since 2017. It's highly effective at preventing pregnancies over its 3-year duration of use. Has a 5-year shelf life, and it is included in the UNFPA and USAID catalogs. And that's important because that's a lot of how this product gets out into the world is through those procurers and through those supply chains. So when we think of what did we do with Levoplant to create the changes to actually increase access and to really change the contraceptive market for implants writ large, this is the picture of where Levoplant was when DKT started working with this product in 2018. So it was registered in 5 countries. The volumes were pretty low, as you might imagine. These aren't the biggest countries in the world. And so it wasn't really moving that much. And so one of the first interventions or prongs of our strategy was a dramatic increase in the access at a national level by going through registrations. And so because this is a WHO pre-qualified product, you can use the WHO collaborative regulatory procedure. It's a bit of a mouthful. But for those of you who are familiar, this is basically a fast-track procedure that you can work with certain regulators who subscribe to then get a shortened registration procedural time. And so the letter of the law is 90 days. Our lived experience is a little bit longer than that, but nonetheless, it's generally quicker than a typical procedure through a national regulatory agency would be. And this is where we are today. And so you can see the dramatic filling in of the map, right? We've colored in a lot of these countries because we've gone through this procedure. And so this has dramatically increased the number of countries where we can supply, which is important in its own right. But there's also, when you go through these things and when you're talking with ministries of health or even with regulators, a question is often like, who else is doing it, right? What other countries are buying this? What other countries have approved it? And so as you keep building more confidence in the product by going through this, it's like, it gathers more momentum, right? The confidence, the knowledge, the different regulators talk at training seminars and congresses that they go to. So there's a real momentum factor that's played a role in accelerating the go-to-market, the product availability across these countries. Of course, this product was also developed and really focused on targeting access issues in the FP 2020 countries. And so that's why, a lot of the green ones are in Africa where we went to market first. A lot of the blue ones, those are where we've submitted. And so those are the ones that have been submitted to the regulators. They're still pending. They're going through the works. But that was in line with our kind of charitable mission of wanting to focus on some of these high prevalence countries first and then looking at additional markets where we can add something to the market, whether it's reduced price, greater access, or some other intervention. Now, another important part of what we did was we've changed pricing. So this is an interesting slide that gives you a lot of history about global contraceptive markets for implants. So on the left here, these are the other implants that exist. There's only 3 qualified implants. And so you can see where the prices were before there was basically a volume guarantee instigated by the donor community in 2013, and that's when the prices plummet. And so that was largely because the donors agreed to finance this, to work together to bring down the pricing. But the Levoplant has always been affordable. And since DKT has taken over this product, we've continued pricing, we've continued pressure, putting down the price as much as we can to increase that availability. And I'll show a little bit of the impact of that later on, but that's just in line with kind of our ethic, our ethos of making these products available, affordable to the extent possible. You can also see here that we've actually decreased the price in the past 3 to 4 years now. When we took over the distribution of this product, it was $8, and we've now pushed it down to $6.70 per unit. And when you think of the volume, we'll get into this in another slide, like we're talking magnitudes of millions of units, that adds up a lot. And since we started working with this product, if we look at the cost of where it was before we took over and the cost of where it is today, multiplied by the units that we're talking about, we've essentially saved global procurers almost $13 million in funds since we started working with them. And that's not just that we're saving money, but that money is still being invested elsewhere. So we're either reaching more women, we're either doing more to train more doctors, right? So this is a net gain in that we're bringing the commodity costs down so that other funds are freed up to be invested elsewhere in MNCH or in family planning or in other parts of the public sector budgets.
5 minutes.
Okay, I'll hurry up. So in terms of the other things that you do to build an enabling environment, we've done a lot of work on increasing access and supporting quality. For us, this is really about clinical training. So making sure that when a woman is getting an implant inserted, that it's a high quality experience. Because for us, quality is not just the product, but it's the entire experience that she has from beginning to end. It's what is she getting counseled on? Are they understanding well the changes that she might experience in her body for the 3 to 6 months afterward? Because that's one of the biggest factors that plays into discontinuation rates. So for us, quality is really a holistic perspective of how do we ensure that this woman is actually achieving her objective of controlling her fertility in a way that meets her expectations. And we've created a bunch of materials that are available online if you want to see videos or some of our other training decks. And then lastly, in order for any of this to work, women themselves have to know about it. And so you have to go out and you have to do advertising and promotion and create demand and generate awareness of these products. And so DKT over the past 4 or 5 years has invested significant effort and energy into creating awareness of the Levoplant. We've run campaigns in countries. You can see we actually have done some kind of like special awareness days where women come into a clinical site after being mobilized by some of our community mobilizers and counseling agents. And you can see a group of happy women who are proud to have had their implant and take power over their future. So when we think of the impact of all this, the results of these interventions, so this is a snapshot of when we look at like the RHSC data on implants procured by globally, all the people who are feeding in data into that, and then we're able to extrapolate also Levoplant's market share. And so the 2 points that I want to make is that since this product was pre-qualified, the big message is that we've increased the entire size of the market. More women are using implants today than were using it 4 or 5 years ago because of this product. Secondly is that we've been able to increase our market share, which in and of itself doesn't really mean anything except for the fact that we're more affordable. And so I'll present further data on what that means for the dollars that are being spent, whether by governments or by UNFPA or USAID, are now going further as a result. So here we go. The UNFPA price indicator, this is published every year. And since we've started programming Levoplant, there's been a dramatic decrease in the dollars that are spent to buy a set of implants. And this is important because, as Josiane said, the donor situation is in flux right now. And so there may be fewer dollars that are going into this. And so it's important that we can make those dollars go further. But an interesting kind of realization that we had, or an interesting insight from this, is that as the prices have gone down, it's actually mobilized more funding from domestic governments. So that's the slide on the right, is actually the governments themselves, when they buy through UNFPA's third-party procurement platform, this is where they're spending their own budgets. And we've seen that in 2021, this data is from 2021, a majority of those who are spending their own money to buy implants were buying Levoplant. Why? Because they get more bang for their buck. Those dollars are going further. They're able to serve more women because of the price interventions that we've made. Another interesting, and I don't want to talk about the other implants too much in a presentation about Levoplant, but an interesting effect is actually there's been significant investments made by other players in the implant industry as a result of increased competition. And so when we think about, what does healthy competition look like, to me, this is a great outcome, is that other folks are investing more in building bigger factories and creating more implants, because we know that this is a method that women want. We know it's highly effective. It meets a lot of the needs, and it has a lot of the characteristics that women want to control their fertility. And so spurring competition and spurring investment, this is not coming from donors. This is coming from industry. They're investing themselves because they've seen the opportunity that's available, and they've been inspired by the market growth to put their own money into creating more access for this product, or at least more capacity and availability. We'll see about the access part. But thank you all so much, and we'll address some questions after this, so thank you again for your attention.
Thank you so much to the last presenter, to True. And I think it really now paves the way for the questions and the discussions that we will have. And one of the very critical issue that we need to be moving into right now in most of our countries is how do we get more domestic funding? How do we get more local governments to invest in contraceptives and moving from funding to financing? So thank you so much for this wonderful presentation. We now have 20 minutes for questions and discussions, which is the most important part of this session. Whoever wants to take the floor may want to raise their hand, present yourself, and maybe walk up to the microphone. Yes, please, go ahead. We'll take a first round of 3. If anybody else wants to follow up the young lady.
I'm Shazina Masood, Pathfinder, Pakistan. And I wanted to ask you a couple of questions. That was a very inspiring presentation. For Level Plant, are you the only one, is DKT or as a subsidiary, are you the only one marketing this? And how does it differ in quality with other implants that are already in the market?
Excellent question. Can we have 2 more before we go back to the presenters? Yes, we have.
Thank you so much. Mine goes to True as well. 2
Your name?
questions. My name is Precious. I work with PSI.
Okay.
My question to you, True, is how are you coordinating with other players to make sure you have competitive prices in the market? And then the second question is, how is this product, which I think is being paid for, competing with the publicly available product, which is free and in some markets is flooding the market and squeezing out the private sector partners?
Excellent question. Yes?
Good morning. My name is Iyaduni Olubode, and my question is for the gentleman from SFH. I was curious about the preference for the injectable in Niger State. It was over 90%. And you presented that you did provide a broad mix to the women. So I was wondering what your best guess is as to why the injectable would be preferable in Niger State. Thank you.
Excellent. Do we have one last one? Okay, True.
Yeah, this is probably easier. Thank you for the questions. So for the first question coming from Pakistan, so DKT is the global distribution and marketing partner for Level Plant. And so that encompasses a few different roles. A lot of that is like the regulatory approach, market introduction, market launch, and then kind of stewardship after that. But in terms of, like, are we the only ones selling it? I would say no, because we sell to MSI. We sell to other partners. Some countries we're selling to a commercial partner who's carrying the product. And so the channels, the variability of the channel of how it actually gets to market is largely decided like at a market level. There are some countries where we have multiple distributors, and that gets to the second question around the pricing competition. But I would say that we are globally responsible for the stewardship of this product, but exactly what that looks like is contingent on the conditions of a country, of a market itself. Yeah, I hope that answers the question. The second part, in terms of differing in quality, so the other 2 implants are, and this is quality is a big topic that we could spend a lot of time on. So there are things like the stringent regulatory approval, an SRA, is like a moniker that's also often used to denote quality. This product is WHO pre-qualified. So the WHO has sent auditors to the site. They've looked at the production processes. They've checked out the dossier. They've audited the API manufacturer. So there's a pretty intensive lift. There's a lot of work and energy that goes into making sure that this product meets quality standards. And that's how you get that kind of fast-track regulatory process that I spoke about. But for DKT, quality takes on, just having a stamp of approval isn't quite enough for us. Like, we think of quality as a system. And so quality is also making sure that the distribution conditions are good for the product, right? That it's being stored and kind of it's going through a supply chain that is responsible. And really what we care about at the end is what is that woman's experience with the product? Yeah. And so going down, I think that is less about Levoplant itself and more a question of like how does social marketing work versus other kinds of supply chains and distribution. And so, the public sector has its own way of doing that, whereas, a purely commercial provider might see that as something that is outside of their obligation. They would say, I just buy and sell a product. I'm just a trader. Whereas as a social marketing organization, like that's a really important part of our DNA, is following that product all the way down to the user level and understanding what his or her experience is. And so we have things like, there's the standard things like checking adverse event reports, or you have kind of like a hotline or a website where you're able to get feedback from the users on their perspectives. But then we also go and we'll do audits with our clinical providers. We'll follow who are we selling to, what is their feedback, how are they receiving comments from their customers, from their patients on the quality of the product. So for us, it's more of a system, a holistic approach to ensuring quality. If I may address the second question as well. This was about coordinating, do we coordinate players and pricing in the marketplace? This is a tricky one because we think about like the supply chain. So there's both public sector and private sector. And we saw in the other presentations that sometimes implants in Nigeria, for example, are free in the public sector, which might be expected. But then even in some private sector outlets, which one might say is like irrational behavior because somebody's paying for that somewhere. And so if it's being given away for free, then the person who's getting the benefit, the woman, isn't necessarily the one who's paying for it. And so from a high level, we try and rationalize the marketplace, and really our obligation, or not obligation, but our desire is to convince women that avoiding a pregnancy for 3 years is worth paying $6.70 for. Right? Like that's a good trade-off, and having the convenience and being able to benefit from the characteristics of an implant is something that's worth paying for. And that's a complement to the domestic resource mobilization conversation, is that, people, if they have the means to pay, it's not unreasonable to expect them to pay for contraception. And so that's another part of it. But we don't mandate pricing, we don't coordinate it at that level. But we certainly try and put into place kind of the mechanisms, the framework that enables social marketing, which is being able to buy and sell products ultimately at a sustainable level, if and where possible. In terms of the free product competition, absolutely. I mean, we see this all the time, that private sector is competing against public sector products that are free. And so people ask, like, it's the exact same product. How do you convince somebody to buy a Levoplant, right? How do you convince a distributor to buy a Levoplant for $6.70 when that exact same product is available for free at the public health clinic down the street? And it's difficult. It's really difficult. And so we have to find, right, is there some kind of segmentation strategy, right? Are we able to cater to a certain clientele in that private sector clinic that wouldn't go to the public sector and who is willing to pay? Or is there some way of differentiating the product itself? So can we have different packaging or other things to make it different? So that's how we try and create that level of differentiation between free and other products. Thank you.
So much. I think we have one last question going to Dr. Anthony Nwala.
Yeah. Okay. Thank you very much, Precious, for that question. There are a lot of factors that could have contributed to this. I'll just outline a few. For the PPMVs in Nigeria, they are able to offer a wide range of products being enabled by the tax shifting, tax sharing policy, where they are trained specifically to offer other products like the implants and every other method. And we found that different states in Nigeria are at different level of implementation of the tax shifting, tax sharing policy. Niger State is not as, at the same level of implementation of TSTS with Lagos State. So that's one factor. And then we also saw the issue of privacy. When we set out, we were thinking that self-injection will be more fashionable in the urban areas. But we found that because of the issue of privacy, Niger State is a predominantly Muslim state. Women, once trained, will prefer to take this to the confine of their homes and give it to themselves right in their own privacy. So that are just some of the factors that may have contributed to that.
Okay, thank you, Dr. Nwala. Do we have any more from the room? Yes, please move up. And the gentleman on that side, do we have another? Do you have a third one? Okay, please go ahead. I don't know whether there's translation though. Yeah. Yes. Thank you.
All right, thank you so much, True. I just wanted to just confirm with True about your product. First, just to confirm that it's
Your name?
subsidized. My name is Wawera and I work with EVAC. Is it a subsidized product? Just confirming that. And so you had to reduce the price from $8 to 6 point something. Are there plans of taking it back now that you've grown, or are you planning on continuously looking for mechanisms to reduce the price? And if it's subsidized, do you have a cost recovery kind of plan for the product? Thanks.
Thank you for your question, Wawera. Shall we take the gentleman on the right before we give the floor back?
Thank you, presenter. I'm Visna from PSI Cambodia.
Okay.
Yeah, I'm really appreciate to having know about label plans. In Cambodia, we launched Jadel implants. But it's two rods the same. But my first question is why label plan just only for three years protection, while Jadel is for 5 year protection. The second one, whether DKT plan to develop the affordable cell injection, again, Sayana President, expensive. Yeah, thank you.
That's all right. Thank you. So for the first question around subsidy for Levoplant, no, it is not subsidized. So we sell at $6.70, and that is unless there are dramatic changes in the cost in production structure, which could happen, inflation is high right now, but otherwise that is a sustainable price point. And we don't plan to increase the price right now. Again, there could be external shocks that change that, but we plan to maintain that pricing as is. So, and we were able to do that. The cost reduction is really a function of scale. Because we're selling more units, we're able to get economies of scale on the production side, and we pass that along to the customer. That's what we wanted. So, but thank you for the question. For the gentleman from Cambodia, for Jadel, so yes, there is a difference in the duration of use, 3 years versus 5 years. And this is really a function of the data that came out of the clinical study. And so when we presented the data from the Levoplant study to the WHO, they looked at it and they took a more conservative approach and improved it for 3 years. However, previous to applying for pre-qualification, the data, some countries had approved it for more than 3 years. And so really it was a judgment call by the WHO, and we've adhered by that. And we actually did just get it registered in Cambodia, by the way, so we can talk after this. As for the question about a self-injectable, so DKT and Woman Care, we're not ourselves a manufacturer, but we work with a lot of manufacturers. And so, I mean, Sinopress is a very interesting product, and there's a lot of interesting data that's coming out around self-injection and self-use. And so we're very interested in this specific product category, and we would love to be the people to bring another Cyanopress to market, if that makes sense. So stay tuned.
Okay, before we conclude, I just wanted to challenge the audience. We heard the first presentation on local manufacturing of contraceptives, which really would contribute to opening up and accessing contraceptives for all. The presenter talked about a partner who would be interested in a 50%, well, he talked about the risks and the challenges, but he also talked about a partner. So now I'm interested in finding out whether in the audience there may be a partner who might be able to be interested. Zaki, what do you say?
Don't be shy. Huh? Only $50 million.
Did I hear 100 million? Okay, well, before we conclude, since there aren't any partners right now, but I'm confident there will be, because the local manufacturing is one very important aspect of being able to make contraceptives available for all, particularly in sub-Saharan Africa. And I think as UNFPA, as also, working on the field, this is something that we've been looking for a long time. So I'm not saying I'm a partner, I'm just saying that it's an interesting topic to follow up on. Before we close, let me give an opportunity to the presenter to say one last word, maybe half a minute. Is that it? We just have half a minute, starting with Zaki and going down and coming back.
Anything from the COVID situation is that how fragile we are in terms of supplying the market with the right in time product. And when we talk about healthcare products, it should be on the top of the pyramids of necessity, or the bottom of the pyramid of necessities. So yes, supplying locally is the solution for basic medicines.
Thank you, Zaki. Paul?
Thanks. Yeah, I mean, tying together, I think some of the themes that I've seen amongst us today, local manufacture, accessible, affordable products, understanding how products are getting into consumers' hands in reality through the complex supply chains and PPMVs in Nigeria, and the price of those products are all essential pieces of information if we want to improve access amongst people that want to access FP. And so, yeah, I just want to thank my fellow presenters for sharing those insights.
Excellent. Thank you, Paul. Dr. Anthony Nwala?
Thank you very much, and thank you to the audience for listening. I think I just want to thank the global community for all the efforts and the work you are putting in, into the health of women across the world. I have also been able to, I believe, convince this audience that the private sector is where we should actually look at. We've always looked at the public sector because of the issues of sustainability, but for actual impact, the private sector is the place to look at. Thank you very much.
Thank you so much. Thank you. True?
Yeah, thank you. Thank you for that, Dr. Nwala. I could not agree more. I would just close by saying that, making markets work is really important, and that's really fundamentally what's going to help increase access, decrease some of the issues that we see in terms of inequity and the barriers that different users face in getting these different products. So finding solutions to make markets work is really what this is all about. Thank you all for attending.
My turn to thank you, all the presenters and the audience, and really to say that this session was really, really, for me, it was a very interesting one for me as a UNFPA representative working on the field and with governments, but also to say that we know universal access coverage cannot be attained without, family planning for all. And we also know that me as a UNFPA representative, one of the major challenges that I have on the field is the lead time from ordering contraceptives to delivering in country. And I heard some very interesting presentations today of how we can not only have pre-qualification that will make them available faster, but also other perspectives of local manufacturing that will make family planning available for all. So I want to thank you again, and I think their abstracts are available on the website if you want to have more information on it. And thank you for being such a good audience. Have a great day. Well done.
Thank you. It's a pleasure to meet you.
Je crois que...
Hi.